sepsis, we've done ARDS. Now we're doing transfusion and blood products. What are the critical care updates over the past year and a half that you definitely should know? So Cochrane Database Transfusion Thresholds Review by Jeffrey Carson. You should know liberal or restrictive transfusion strategies in patients with traumatic brain injury. You should know the incidence of trolley using active surveillance, and that was published actually 2024. And then plasma transfusions in the ICU. So hemoglobin thresholds for RBC transfusion, Cochrane database, restrictive strategy, 7 to 8 for most patients, no mortality increase, acute MI, liberal strategy may lower death, recurrent MI risk, brain injury, liberal strategy, improved neurologic outcomes, GI bleed, restrictive strategy, decreased 30-day mortality. Liberal transfusion carries more complications overall. It was one of the takeaway messages, but know that there is a guideline out there, hemoglobin thresholds, published in 2025. The HEMOTION trial was a blood transfusion strategy in traumatic brain injury over the last 2 years, and they looked at restrictive versus liberal threshold. And the restrictive, there was a trend towards worse neurologic outcomes, a trend, but it was non-significant. Mortality and VTE rates similar between strategies. The practice advised to still target hemoglobin above 7 to 8. Understanding that the ARDS rate in the liberal was 3 times as high as the restrictive group. So if you have only a trend towards worse neurologic outcomes, but you have a higher ARDS rate, then you're going to pick your poison. Incidence of transfusion-related acute lung injury, active surveillance. So used to say 1 trolley case per 10,000 plasma units, but now it's higher. It's 3.19 per 10,000 plasma units. RBCs are much less likely to cause a trolley. That's that. Inappropriate use of plasma in the ICU. So 10% of ICU patients received 1 or more plasma transfusions. Common misuse, mild INR elevation in non-bleeding patients. Plasma should be reserved for clear clinical rationale. 37% of plasma transfusions lacked a strong clinical indication. So that's an interesting input trial, transfusion 2025. So restrictive hemoglobin threshold for most ICU patients, 7 to 8, no mortality increase. HEMOTION is liberal or restrictive transfusions after TBI, and the answer was neither was clearly superior. Trolley incidence, and what proportion of ICU plasma transfusion lacked a strong indication? 37%. The next topic is sedation, delirium, and airway. We'll look at the update to the clinical PADIS, immobility and sleep, or the IS. We'll look at some of the postoperative delirium data, ketamine versus etomidate, hyperangulated versus MAC blades, and restrictive versus liberal physical restraint. So Precedex for pain, agitation, and delirium, the most recent PADIS focused update, critical care medicine 2025. So you have a reduction in delirium prevalence and duration, increased bradycardia risk, and this is with Precedex versus dexmedetomidine versus Propofol. There was no effect on mortality. Bradycardia risk is definitely higher. So, now Precedex is basically better in terms of delirium prevention, but it does have an increased risk of bradycardia. Updated guidelines on post-op delirium, pre-op screening for post-op risk factors. Precedex is associated with lower post-op delirium. So if you have a patient going for an operation in the SICU, using dexmedetomidine to reduce post-op delirium in high-risk patients is now advised. Ketamine versus etomidate for rapid sequence intubation. Randomized induction agent for RSI. There was no difference in the sepsis subgroup. Comparable safety profile. 28-day mortality was about the same. You should know at least that ketamine can blunt your pressor response, and etomidate can cause low cortisol, make you basically adrenal insufficient. That is the discussion key points of ketamine versus etomidate. Video laryngoscopy blade for difficult intubation. So anesthesia 2024, they looked at hyperangulated D blade versus standard Macintosh blade, and I could show you what that means. There was a lower rate of failed intubation with the hyperangulated. Look at the first attempt to success. That's why we really start using hyperangulated blades now. That's what the hyperangulated blade looks like, a Macintosh, a Miller, and we use the this rigid stylet. Physical restraint strategies in ventilated patients. R2D2 ICU, mechanically ventilated, the restrictive group, severe agitation only, versus systematic wrist restraint use, similar days alive without coma, self-extubation, supports limiting restraint use in low agitation risk. So restrictive restraint use was non-inferior to systematic wrist restraint use. So there's no benefit for systematic wrist restraint use in the ICU. So first line sedation agent per the new SCCM PAD guideline, dexmedetomidine. Ketamine versus etomidate, mortality difference, none. Hyperangulated blade versus Macintosh, first attempt success, much higher with hyperangulated. R2D2, restrictive, is it safe? Yes. And post-op delirium guideline, what's the key non-drug step? I forgot to mention multi-component non-pharmacologic interventions. And that's what we'll do there, and then we'll move on.